This talk is a little bit of a misnomer because we really don't have instant solutions that are pharmacological for high-risk kids. But one of the things I'm going to talk about is what you don't do. And to tell you the truth, I'm more of a psychotherapy researcher than a pharmacologist. So I'm going to talk about some of the non-pharmacologic aspects of management that complement pharmacologic treatment. The other thing is that I think in the objectives initially, I was going to talk about the management of concussion, and that really turned out to be overly ambitious. So I'm not going to talk about that this morning. We have a case conference in the afternoon, which Matt and I co-chair. And if you want, we can begin by talking about that, or we can do something else with it. But I have prepared something if that's something that people had wanted to hear about. So what we will talk about today, this morning, is what are the determinants and contributors to imminent suicidal risk, and then talk about some pharmacologic approaches, including medications that you should not use, to target depression, anxiety, and sleep. If we have time, I'll talk about the approach to understanding irritability and emotion dysregulation. But I'm not sure we'll have time, but you have it in your slides. Just in terms of financial disclosure, I don't think I have any conflict of interest for what I'm talking about today, but I do get some royalties from an instrument that I developed and from a book that's sold, I think, 1,100 copies. And also I'm on the editorial board of Up to Date. So imminent suicidal risk means what factors which push somebody to commit or attempt suicide right now. And so not all suicide risk factors are in that category. And consequently, although they may be helpful in telling you that somebody's at risk over their lifetime, they don't necessarily help you deciding in the office, in the emergency department, can you send them home or not? The most common reasons that kids give for making a suicide attempt are that they can't stand the feeling, or that they want to escape a possible impossible situation, which we can put under the idea of distress. And so that one way to conceptualize suicide is that it ensues as a result of a desire to escape from intolerable, or I would say perceived intolerable distress, combined with an inability to inhibit or delay a response to that distress. And I made this slide myself, and it shows, I think. But so that the pathway from distress to suicide, it's facilitated by disinhibition, by availability of lethal agents, and it can be buffered by social support and some ability to tolerate distress, including psychotherapeutic approaches. In terms of the progression of suicidal risk, what we know is that if somebody has suicidal ideation, about a little less than a third of those folks will go on to make a suicide attempt within a year, whereas a little bit more than half of people who have a suicidal plan will make an attempt within a year. And the things that cause people to progress, I put that in quotes, but to move from ideation to an attempt, are disorders of distress, as termed by Matthew Knock. So comorbidities like panic disorder, anxiety, post-traumatic stress disorder, and disorders of anger and impulsivity that relate to a decreased ability to inhibit a response to distress. And so those are things like oppositional disorder, conduct disorder, and substance abuse. And incidentally, conduct disorder also increases your risk for suicidal behavior in another way, because those kids generate life events like incarceration that precipitate suicidal crises. And then one disorder that falls into both categories is bipolar disorder, where you have both the distress and depression and the disinhibition. Often you see both in a mixed state, which is the state that is the most common state for a bipolar kid to be in when they attempt or complete suicide. So as a schematic, we're not going to talk about all these conditions, but depression is primarily a disorder of distress, as is anxiety. Insomnia has some impact on both, as does having a mixed state or somebody who's psychotic. Alcohol and substance abuse is more so a disinhibition, although there are pharmacologic effects of alcohol that can cause a low or a labile mood. So depression is the most common and the strongest correlate of suicidal ideation and behavior, although it usually doesn't act alone. And so as I had just said, depression is usually in combination with some difficulty in disinhibition, such as a disorder of anger or impulsivity, or other things that increase distress. Those are the kids who are depressed who are at most risk for suicide. There's no quick fix for depression, although I will give you a glimpse of what some of our colleagues in adult psychiatry are doing. And so that most psychotherapeutic or pharmacologic interventions take 4 to 6 weeks. This is why developing a safety plan is important. And I don't know why that slide shows up where it does in my presentation. And so when I talk about it, it'll be a little out of order, but I think it's something that is important to do initially to help people have some ways of coping with the stress before some of these other interventions are going to take effect. So the most common pharmacologic intervention for pediatric depression are SSRIs. There are 2 that are indicated for adolescent depression, fluoxetine and escitalopram. And the indications are moderate to severe depression. There's some evidence that a family history of response will increase the odds of a response. And say somebody who may be in a less severe category, particularly what in DSM-4 was known as dysthymic disorder, that didn't respond to psychotherapy. Contraindications, allergy, bipolar depression, without a mood stabilization, you're going to flip somebody into mania, and psychosis, where the even if they have a psychotic depression, the antidepressant alone isn't sufficient. So we're going to go over 8 habits of successful SSRI prescribers, and they are education, assessment for adverse outcomes, trying to push for an early response, prescribing an adequate dose, monitoring adherence, monitoring for adverse events and having a safety plan, treating to remission, and having a plan for continuation treatment after you get symptomatic response. So in terms of education, I think Guy has laid out some of the frameworks of this, but you want to diffuse the blaming that often goes on when a kid is initially found to be depressed. It's an illness, it's common, it's nobody's fault, and it's treatable. And also, you want to let people know from the beginning that this is going to take a while. There may be some trial and error. The first medication may not work. So you want to educate people about what are the different options and what's going to ensue. And at the beginning, you want to ask people, to what degree are they hopeful that you're going to be able to help them? If they say that they aren't that hopeful, you might ask, well, what are the things that might make you more hopeful? And if they are hopeful, you want to find out what are the things that might make them more hopeless, because you want to avoid doing things that might give them that idea. And similarly, if there are things that can make them more hopeful and you can do those things, then it makes sense to do so. In terms of a psychosocial assessment, there are certain things that are going to make people less likely to respond to medication or psychotherapy. And so you want to try to uncover those because they're interventions that go outside of the individual, and if they aren't dealt with, a kid's not going to get better. So if a parent is depressed, if a kid's being bullied at school, they're not going to recover until that is dealt with. Kids who have same-sex attraction and that's not dealt with in some way, and it's associated with other problems like family rejection or the kid worrying about what's going to happen when he or she comes to terms with this. A lot of parent-child discord. A history of abuse seems to confer more difficulty in treatment response. And then other comorbidities, which sometimes are more the problem than the depression. You want to be able to identify those and then reprioritize your intervention if indeed those are the things that are really driving the kid's problems. When to get lab tests, I don't think anybody really knows, but we do know that if you take every kid with a first episode depression and get lab tests, you're not going to find very much. So we will generally get lab tests for kids with chronic depression or recurrent depression, or where kids have symptoms that are out of proportion to the rest of their setting, like really difficult sleep problems, or kids with very prominent fatigue. And these are the kind of things that we'll screen for. We'll recommend sleep studies if the sleep symptoms are unresponsive to reasonable psychosocial or medical intervention. And we do get antidepressant levels to monitor adherence and detect kids who have rapid metabolism. We won't do that routinely, but if they fail to respond to an initial trial with an antidepressant, we may get a level before we switch, and certainly when they failed to respond to a second antidepressant, we'll get a level both to determine adherence and just to see whether or not they're getting adequate exposure. In terms of a choice of antidepressant, fluoxetine has the strongest track record. It's a little difficult to compare to the other antidepressants because those studies were also the best conducted, so it's a confound. It's somewhat of an activating agent for most people, so it may be more useful with people with fatigue or who are slowed down, but at least clinically, for people with a lot of agitation, it may make them more so. If you're worried about mania, say that there's a family history or you have some concern based on their clinical presentation, it's probably not the best drug to start with because it has a long half-life, so that any decision that you make you're going to have to live with and the kid's going to have to live with it. So it may be better to start with a drug with a shorter half-life. Escitalopram it's the cleanest of the SSRIs and the most purely serotonergic, and it has the fewest drug interactions. So if you're managing somebody with medical comorbidity, it's something to think about. Sertraline has been demonstrated to be efficacious, although the clinical trials, which weren't that well done, the effects aren't that strong, but it has a very strong record in treatment of OCD and anxiety. So it might be something you would consider if the kid has prominent anxiety. The SNRIs, like venlafaxine or duloxetine, should not be first-line drugs, but they may be useful with kids with pain syndromes. Paroxetine should not be used. It's been shown not to be efficacious for adolescent depression. Bupropion is a different class of antidepressant. It's very activated. It's activating. It's the only drug that actually is associated with weight loss in clinical trials. And it's been shown to be efficacious against ADHD, although not to the same degree as stimulants. So it may be useful in kids who are fatigued or kids with comorbid ADHD. But there's never been an RCT, and based on my conversations with NIMH, there probably never will be. So, we're sort of left with clinical judgment on that one. The next category of being successful, quote unquote, is try and push for an early response. This comes from the Tortious study that we were one of the sites and were involved in conducting. And what you can see is that the people who remit in treatment separate from the people who don't remit very early in treatment. And this is even adjusting for a variety of other differences between them at baseline, but you can see that they start with a similar severity. And this is becoming wider and more widely accepted, that getting an early response is really key to having a successful outcome. And so in the Tortious study, we found that early augmentation with therapy were with other pharmacological agents, such as mood stabilizers, although I'm not recommending that. Something for some kids who did respond to other things that we had to do. That they seem to have a better outcome if you intervene early. And we also know that the suicidal event, it happens early in the treatment, and it tends to occur in people who aren't responding. Now, this is a little window, something that we may say be doing, but people are using ketamine, which is a glutamatergic agent, and it's used as an anesthetic. Giving an IV, the study was they gave an IV bolus, suicidal depressed adult. And where I showed you that other slide, here the scale is in weeks. This scale is in minutes. It's kind of an amazing. We know what their long-term effects are, and I'm sure there's going to be some. But you can get this dramatic response in terms of depression in very rapidly. And in these patients, we also had a suicidal ideation. Just something to think about. Back to that way, because if kids develop side effects, they may refuse then to try anything else. So, and then we'll go to the equivalent of 20 milligrams of fluoxetine, citalopram is the same dosing, and reevaluate. If they're not symptomatic, there are data to support an increase. And then these are the same kind of dosing escalation that we do with other drugs. There's a warning about citalopram and escitalopram that it causes QTc prolongation at levels over 40 milligrams. I think this is overkill, but we're sort of stuck with it. The data are mostly in beagles, which, I'm worried about beagles too, but I don't know what you can generalize. And it's been based on overdoses that people have done rather than, actual monitoring of people in clinical trials. And by 6 to 8 weeks, you should know whether or not a drug is going to be effective. Although the conventional wisdom is that drug concentration in the SSRIs doesn't matter, it does. We were able to demonstrate that in the Tortious study, and at least in fluoxetine and citalopram, the kids who had higher blood concentrations of the drug were more likely to respond. And we actually had an interesting natural experiment. So if you look at the third set of bars there, if the kid, at 6 weeks, if a kid didn't respond, we would increase their dose. And if we increase the dose, and at 12 weeks, we weren't able to increase their blood concentration, then they had less than a 10% response rate. On the other hand, if their blood concentration went above the geometric mean, then we had like a 65% response rate. On the other hand, if their level was already quote unquote adequate at 6 weeks, then they had an adequate response, about the same response rate at 12 weeks. And there's a lot of scatter, so I can't give you a number that a cut point. But it's just that I think this flies in the face of something that we've been taught for a long time is that blood levels don't matter at all. We also found that adherence matters, so that if you look at pill count remainders, have the kid bring in the pill bottle, see how many pills are left compared to what they should be taking, and you can see there's a very nice step function in terms of predicting treatment response. And that's something that we don't do clinically, but yet it's very, very simple. And you know, you can see that you could improve your response rate significantly. In terms of, we recommend seeing people weekly for the first 4 weeks. I know in primary care that's not always practical, but then try and assess them over the phone. But it's just that the problems emerge early, so that mania often emerges at the average time is about 4 to 5 weeks. Suicidal events in the first couple of weeks, and so on. So that's the time when you want to be keeping a closer eye on them and looking for other types of symptoms that they're not going to be able to tolerate. So, long list of side effects. I'm going to talk about the detection and management of a few of these. So, one of the most common is fatigue, and so. Before I go into the specifics, I think one of the reasons that I think we got the black box warning was a clinical view that the side effects that people were reporting were all in their head, or they were attributable to depression. And the fact is, the clinical trials show that there is a small signal for suicidal events, and that our position should be that if somebody didn't have a problem and you start the drug and then they have a problem, that you should assume that that's a side effect related to the drug until proven otherwise, rather than if the burden of proof is on the patient to tell you, to convince you that it's really a problem. But if you see fatigue, then you may switch the dose to the evening. You want to make sure the kid's actually sleeping okay. And if they've had otherwise a good response, we augment with bupropion. And some of the side effects that people have, they really can't tolerate, and you either want to drop the dose or switch to a different antidepressant. Sometimes kids will gain a lot of weight. They develop akathisia. That usually happens early, where they just can't sit still. They feel very uncomfortable. Kids will develop, what they have is vivid dreams. So if they have bad dreams, they have nightmares that can be very disruptive. And mania, that goes without saying, I guess, that's something where you want to make discontinue or drop the dose. So the things that you might anticipate somebody develop mania would be if they have a family history, early onset depression, people with a history of hypomania, although then I would be very, very careful. And generally my first thought would be to either use light or use cognitive behavior therapy rather than medication. And somebody with psychotic depression, they have a high rate of development of mania. And in the study by Andres Martin, about 5% of kids develop a manic response to an antidepressant. There was recently a meta-analysis that showed a higher rate, about 9%, which seems, really high to me. But that's something that just was reported in the literature. I think this is more real because this is based on a pharmacoepidemiologic database, whereas this other meta-analysis came from clinical trials. And we all know that, they don't really represent the patients that we see. And I think that the issue of subsyndromal mania may be an important one. In the Tordia study, what we found is that one of the only things that differentiated between the people who remitted and those that didn't were people with subsyndromal mania. And these are manic symptoms at a level that you would not start a mood stabilizer. And so all I would say is I don't know that we have a recommendation for clinical practice now, but it suggests to me that we need to study this and look at this more carefully. And in the adult literature, there's evidence that people with subsyndromal mania have a much more difficult course. And the question is, is there something else that we should be doing for them? So the suicidal events and SRIs has been, a huge issue, and it's actually led to a decline in prescription rates, and which may or may not be a good thing, but it's also led to a decline in the rate of depression diagnosis in primary care, which is a problem. And there's not been an offset for in terms of increased referrals to psychotherapy. So I think it's created a sense of therapeutic nihilism, that people don't want to deal with depression because then they're going to get into this issue. The actual risk difference between drug and placebo is 0.9%. It is twice as high, and so when the New York Times said suicide twice as high in antidepressants, that's really scary. It's not as interesting a headline to say 0.9% difference, and it's not suicide, it's increase in ideation or attempt. There were no suicides in any of the 4,300 kids that were treated. So that I think, although we need to take it seriously, I think the main clinical significance of suicidal events is that it makes people scared, and that we now need to deal with it, in a more proactive way. The things that lead to suicidal events in treatment are similar to those that would happen in anybody, whether they're being treated or not. High level of depression, slow degree of improvement, high ideation, non-suicidal self-injury, which was kind of a surprise to us, but there have been now a number of studies that have shown that that's a significant risk factor for a suicide attempt. Alcohol or drug use and family discord. And so if you run into a kid who shows increase in suicidality, in my clinical experience, it's usually accompanied by some deterioration in mood or activation. You withdraw the drug. You may lower it if they've had a reasonable response before that. But I think the burden of proof is on us to disprove to the family that it's attributable to the drug. So that, our fallback position should be, okay, we need to do something about this. And then there are other alternative treatments. There's good psychotherapies and light. But on the other hand, we have to remember that there's also a risk of doing nothing, that the risk of suicide, that depression is a potentially fatal illness, so that the choice isn't between medication, suicidal ideation, let's do nothing. It's between, okay, that didn't work, but your kid is still at risk, and we need to find some way to deal with it. And this just illustrates this issue about the relationship between a slow response, severity, and suicidal events. The red are the suicidal serious adverse events. And you can see that these kids, when they came into this particular study, they had an SIQ, the Suicide Ideation Questionnaire, of 60. 31 is a clinical cutoff for clinically significant suicidal ideation. And you could say, even though they showed some modest treatment response, by the end of 12 weeks, they're still way over the clinical cutoff. So it's not surprising that that's the group that, developed the events. And so it just gets back to the idea that we either need to do something to accelerate treatment response or to be able to tolerate that distress until relief is on the way. Just to put the idea of the risks and benefits of antidepressants in some context. So the first is the meta-analysis that shows the difference between drug and placebo in terms of response. The second is the difference in the rate of events, which is modest. And then there's a metric called the number needed to treat. The smaller the number, the more potent the effect. And you can see there's a number needed to treat. I think it's 10, which is not a super strong effect, but it's a signal. But the number needed to harm to create a suicidal event is 112. So one way to talk with families is to say, there is a real risk of an event, but your kid is 11 times more likely to respond than to develop an event. It's up to the family to decide if that's an adequate risk-benefit ratio for them. It's our job to make sure that they have the facts in order to make an informed decision, not based on scary headlines. So after you get a treatment response, the next step is treatment consolidation and continuation. And so what you want to do in this one is focus on what are the residual symptoms, and then after you get remission, you need to treat for another 6 to 12 months, or else there's a significant risk of relapse. Now I think I understand why the safety plan shows up here, because I was saying that you need to do something to keep people in check until the other interventions kick in. So this is a fairly accepted approach for a safety plan. It's never really been formally evaluated. Mary Jane Rotherham Boris in '91 did a quasi-experimental study in which she assigned one group home for runaway youth, really high-risk kids, to get this plan, and then another one didn't. And she did show lower rates of attempts in the group home that got the intervention. And as far as I know, that's it. But there's 3 levels of interventions. There are personal strategies that you can do, that you work on with the kid: distraction, being able to tolerate distress, thinking about reasons for living. One kid we helped, he wanted to be a CEO of a company, so we had him make a business card he could look at, whenever he got freaked out. Some people think about a favorite place, they look at a picture of their pet. Then the second level is reaching out to people. So whether it's parents, adults, the point though is we want to make sure that they're reaching out for support. The expectation is not that these folks are going to do some kind of clinical intervention. And then if that doesn't hold them, then they need to get professional help. And naturally, we have them remove or secure any lethal agents. And so I think doing something like this, making sure there's something in place that can help that kid and family keep the kid in check until the distress is diminished, I think is an important component. Back to, that was like a commercial break for safety plans, I guess, but back to our presentation. Here you can see Graham Emsley did an RCT where he had people that he got better and then randomized them to continue on fluoxetine or on placebo. And you can see that the number of people that stayed well, was really different between the groups over time. And you can see that at 6 months, the groups are really strongly separating by 6 or 7 months. And there was one study from the same group that added a type of CBT oriented to helping the kids stay well, and they had even better results. So there are things that we can do to keep people well once they get well. I think that you can't really just give drugs. And I think that one of the things that's a huge stressor for kids, even if they're not being bullied, is, they're usually falling behind academically, there's some social issues, and we almost routinely will facilitate a meeting with the school. Sometimes parents want to do it themselves, but often we'll send a clinician to the school and meet with them and try and work out some kind of debt relief. If the kid is behind in school, they then will give up because they don't think they can ever get caught up. And, we may say, maybe you don't have to take 5 AP classes. Maybe you can take 3. And to just try to either, get the workload to something that they can manage. And clearly, if there's an issue with bullying, we will go and help the parents to advocate for the fact that schools are legally mandated to do something about it. And even that intervention, even if the schools don't follow through, is to say to the kid, this isn't your fault. This is their fault. They need to do something about it. If they don't, we will help you to deal with it, but just know that this isn't coming from you. And there are lots of things that we can do that are very simple that can help parents to be more effective with these kids. A lot of times when kids get depressed, the parents sort of feel like, oh, does my usual parenting, is that applicable anymore? Can I even criticize the kid? You know what? And so I think just some basic education about how to, how to approach the kid, what are the ground rules, are really important. And I think that Guy's treatment model is really a particularly useful approach to doing this. For kids who are partial responders, so then, you have a discussion, but often you'll stay with that antidepressant, maybe get a drug level to see if you want to go up on the dose. You want to rule out other, medical comorbidities, or are there other psychiatric comorbidities that contributed to this? And then the most common thing we do is augment with bupropion. Some of these other agents we have used, to tell you the truth, it's very difficult for me to convince somebody to go on lithium by the time you go through all the side effects. Well, it's a really good drug, it'll make you fat, you'll get acne, but believe me, you'll feel better. I don't know, maybe I have to change my pitch, but for people who actually don't respond, then, again, you want to document adherence before you then go on a wild goose chase with another drug when they weren't taking the first one. And then the most logical thing is to switch to another SSRI. This is based on the results of the Tortious study, and to augment with psychotherapy if they haven't had it before. The third step, we're never going to actually do that study, and even in STAR-D, which was $36 million, it's not so definitive. But basically, you'll either augment or switch to some other agent. Anxiety, I'm not going to talk a lot about, except to say that, often they're comorbid with depression, and it can be a significant source of distress. And the SSRIs are actually much better, more effective against anxiety than they are for depression, so that the number needed to treat is 3. There's about a 33% difference between drug and placebo, as compared to a 10 to 20% difference for depression. The conventional wisdom is that the dose may need to be higher than for the treatment of depression. That's only been proven in obsessive compulsive disorder in adults, but that's generally what we've been taught. And the combination of CBT and an SSRI will give you the best results. And the active ingredient in CBT is really not the C. It's the graduated exposure. There's no way to get over anxiety except by being in a situation where you can experience mastery with it. Now, what about benzodiazepines? I don't like them. Our department, I think, has a bias against it, and there are other groups that I think legitimately view, that there's some judicious role for them. And I think that when they're indicated when anxiety is the main or sole contributor to distress, and where you're using it until the SSRI and or CBT kick in, and where the family and patient are committed to longer-term work to manage the anxiety. You would be much less likely to use it in somebody where there's a risk for substance abuse. However, we have some data that it may increase the risk for suicidal events. And in the Tortious study, this was a small sample. Kids weren't randomly assigned, but the kids who got benzodiazepines were much, much more likely to have a suicidal event or non-suicidal self-injury, even after controlling for the differences between the ones who got the benzodiazepine and the ones who didn't. And it makes some sense. We know in adults hypnotics are associated with a risk for suicide and suicidal behavior, and that in some kids it may have a disinhibiting effect. Sleep, last frontier. I think that given the frequency of sleep problems, I think our training in psychiatry is really weak. And I'm sure in pediatrics it's not great either. I trained as a pediatrician, but that was a long time ago. But insomnia is the single most prominent symptom of depression that's found in the week before suicide. And there have been now study after study that show that it predicts self-harm, even controlling for depression and suicidal ideation. And in lab studies where they'll sleep-deprived kids, they show evidence of increased impulsivity, like your grandmother could tell you that, but that they tend to have a greater negative affective bias, a greater reward response, and less likelihood to respond to antidepressants. So it's like a perfect storm for suicidal behavior. And treatment for depression doesn't necessarily improve sleep, and sometimes SSRIs can make sleep worse. So you can't go on autopilot just because the kid is responding or at least taking an antidepressant. And some of these slides come from a colleague of mine, Dana McMakin, who's a rising star in sleep research and affective neuroscience. And this is one of the studies she's done where she's either had kids sleep extension, meaning they're sleeping the amount they really need to, versus sleep restriction, and then measuring a physiologic measure of emotional reactivity. And what you can see here, or I'll tell you what you're seeing, which is a greater valence to negative emotional stimuli. And this is just another way of showing this, but this was in a peer interaction where they were coding for negative affect, and that the kids who were sleep restricted were more likely to get into it with other kids. So there are a bunch of different problems that you often have with sleep: going to bed, falling asleep, interrupted sleep, and then waking up. I guess that's obvious. And then some kids, their main problem is fatigue during the day. The things that you want to target fall into three categories. One is some difficulty with hypervigilance at the time of bedtime. A second is that kids have difficulty disengaging. Either they have too much work or they're, on the phone and activated. And then there are kids who have either phase delay or they have difficulty waking up. And one thing I want to say is that there are brief non-pharmacologic interventions that are effective. One study that was done in schools that identified kids with sleep problems, a 1 to 2 session intervention in a group showed changes in the kids' behavior and mood that lasted throughout the school year. And there are other studies in primary care. And so I think although I will mention some reasonable pharmacologic approaches, we have really potent and simple psychosocial interventions for sleep difficulties. So if you have a kid who's going to bed, have trouble going to bed, the most common problem are things like they either are overstimulated or they have too much work, and so those are the things that you would target. You do have kids who have a phase delay. You see kids who, on the weekend, they stay up, much later, and then, they have trouble then re-entering the school week. You can see that in the summer where it could take them the month of September to get back. And so there are techniques where you gradually advance the time when they wake up. And then you have kids where the reason that they have trouble going to bed is avoidance, because they really have trouble getting to sleep. And we'll talk about that in a minute. So it sounds really simple, but sometimes we forget when we're rushed. But that it's really important to turn out the lights. That'll suppress, that even moderate light will suppress melatonin. Get rid of the cell phones, the computers, and then if you do get up, don't turn the lights on. So I don't know what happened to that slide, but I think probably the headline says it all. Okay. So the goal is that you don't want to have more than 2 hours variation between the weekend and the week. And so that you can advance the kid's bedtime, say, by a half an hour a week. You can't do it too fast. And you also want to avoid naps during the day. And sometimes you can give light in the morning, light treatment to help with the phase advance. Now, what about trouble falling asleep? So now the kid's in bed, they can't fall asleep. Well, one reason is they nap in the afternoon, or they use a lot of caffeine, or, they're involved with social media. One not too uncommon cause is restless leg syndrome. And interestingly, this is much, much more common in people with iron deficiency anemia. And so if you get a history of kids who have difficulty finding a position of rest and find themselves moving around and having very restless sleep, it's reasonable to see whether or not that's the case. And then finally, the biggest category are kids who are ruminating or have anxiety before going to bed. And there, the technique is something to counter that, either relaxing, some kind of imagery, and a technique that Dana has been working on called savoring that I'll mention briefly. And so one of the things, though, is you want the kids to go to bed when they're sleepy. Sometimes kids will be sleepy, and they'll sort of keep working or keep doing whatever. And then if they can't get to sleep, they shouldn't stay in the bed. They should get out. The bed is just for sleeping so that they don't condition that with, worrying about sleep. Yay. I didn't know this was going to be like this, but at any rate, savoring is a technique where you think about positive things that you rehearse, beforehand, and that you use that to counter the rumination. So that it's two effects. One is you can't savor and ruminate at the same time. And secondly, it in itself is relaxing and facilitating. And, one of the techniques that Dana uses, imagine a mental television, and now kids will say, what's a television? But, whatever, some video thing, and you think about something like, some experience you had that was really relaxing or really enjoyable. And probably it has some mirror image neurobiological component to it, to rumination. Now, what about sleep interruptions? So nightmares is a common problem, and it can be a side effect of SSRIs. You have more vivid dreams, so it can really be very disruptive. So there you would lower the dose or switch to a different one, and often the kid won't have a problem with a different one. If the kid has PTSD, then there are actually cognitive behavioral techniques of rehearsal, that 1 or 2 sessions where you can deal with nightmares. I don't know how to do it, but I know people who do. You can also use prazosin, which has been shown to be effective against nightmares in people with PTSD. I think for a lot of these other things, these are times you want to refer to a sleep specialist for an evaluation. And then there are other, medication and substance effects where you want to somehow control the use or alter the timing. So, for example, you might have a kid who's on stimulants. For some reason, like on the weekend, they wake up at noon and then they take the stimulant. Well, then they can't get to bed till late. So those are things that are easily dealt with. In terms of pharmacologic interventions, Benadryl, diphenhydramine, there's one positive and one negative trial. It's amazing given how frequently it's used. It's pretty benign, but it does have some anticholinergic side effects. Mirtazapine, Remeron, this is an antidepressant that doesn't work very well in kids, but at a lower dose, it's quite sedating, and it can cause weight gain. So it may be useful in somebody who's skinny and who actually wants to gain weight, but you have to be careful if that isn't their intent. Amitriptyline is used often also as a treatment for migraine. There's never been an RCT, but it's very commonly prescribed. But there you could do double duty because it also does help sleep. The GABA agonists I do not recommend. They are not as benign as profiled. They tend to be habit-forming and can be associated with parasomnias and with a hangover, so to speak, in the morning. I really don't think they're a good idea. When we have, good psychosocial interventions, some other, more benign medications, I don't really think these have a role except if a sleep specialist is managing them and feels like, there's no other alternative. Trazodone, which historically has been the most commonly used sleep aid in people managing depression, I do not recommend. First of all, it's associated with priapism in boys. It's rare, but it's a really bad complication if it occurs. Though when you describe it to boys at first, they think it's a good thing. But when you explain the long-term consequences, they find it a little more sobering. It also can cause serotonin syndrome in combination with another serotonergic agent. And there's no data to support its efficacy. And in addition, in the Tordia trial, the clinicians were allowed to use sleep aids as clinically deemed. And we had an incredibly low treatment response rate in those that got concomitant trazodone. And we wondered why, and we wrote this up, submitted it to a journal, and the review came back, and one of the reviewers said, "Did you know that trazodone is metabolized to methylchlorpiprazine?" I'm sure everybody here knew that, but I didn't remember that. But I did remember MCPP was used in the 80s when I was training, in my early faculty career, as an infusion agent to induce anxiety and dysphoria. And the person then wrote, "And did you know that drugs that inhibit 2D6, the cytochrome, will cause an accumulation of MCPP, drugs such as fluoxetine and paroxetine?" They said, "I suggest that you look at the response rate in the people that got those drugs compared to the other drugs in your study." So we did. Anybody want to guess what the response rate was in the people who got fluoxetine or paroxetine? It's not a fair question, really, but nobody responded. None of the people that got that. And in the ones that were partial inhibitors, we had like a 20 to 30% response rate. And in the drugs that had no effect, we had like a 40% response rate. So it suggests that there's not a good interaction going on with some of the antidepressants. Interestingly, in adults, there have been reports that it's used, with fluoxetine without any problem. But for me, this was really sobering, and I don't need more evidence. I don't want to get more evidence, so I work around it. And you guys have been cautioned, and you can do what you want. So melatonin, though, is a good agent. It's a natural substance. You can get it, in a drugstore without a prescription. There are some formulations that are better than others, and I don't remember the ones that are, but I think I remember the initials, but I don't know that does any good to you. But one is USP. I think it's U.S. Pharmacopoeia. Anyway, there are some of them that are more standard, and that you're more sure of getting actually the product you're buying. There have been clinical trials in kids with ADHD and autism that show a good effect, and there are no long-term effects. There was one report that it may increase the immune response, and people caution against using it in immunoproliferative disorders. I don't really know much about this, but I'm passing this on to you. And then there's this other agent, ramelteon, which is a melatonin receptor agonist, and it's been used in adults. However, it's associated with hyperprolactinemia. So, I would say, why use it in kids? But it has a better side effect profile than some of the other agents. And this just is a meta-analysis of the effects of melatonin. They're pretty consistent. It's not a huge effect. The other thing to keep in mind is if you have a kid that's having trouble not only getting to sleep but staying asleep, you can use a combination of an extended release melatonin and one that, the regular melatonin, which really is only efficacious in the first 45 minutes of sleep. So, how are we doing for time, by the way? We have 10 minutes? Okay. So, in terms of just summarizing how you approach sleep problems, you want to determine when the problem is occurring, and then what's the context and what things are driving the problem. Is it the routine, other medications, rumination, overstimulation? And then you want to recommend changes in the routine and psychosocial interventions, and then consider medication. And I would say melatonin is safe and efficacious, especially for difficulty falling asleep. And you can use the extended release if they have some sleep continuity disturbance. I'll just talk a little bit about this, and then I'd like to leave some time for questions, because I think that for the most part, dealing with kids with mood lability and irritability is something you don't want to do in primary care. But you do want to know how to detect it and what to do next. And so this is important with regard to suicide because it's one of the final common pathways for suicidal behavior. It's very nonspecific. Almost every psychiatric disorder has irritability or mood lability associated with it. Oppositional defiant disorder, conduct disorder, attention deficit disorder, mood disorder. So therefore, the management of it may have to depend on what it is that's driving the ability in the first place. So, for example, if it's secondary to substance abuse, sleep deprivation, caffeine use, or a side effect of medication, then you deal with that rather than adding something else on top of this. If lability is a symptom of depression in the absence of hypomanic symptoms, then I would say continue treating with an antidepressant and using psychosocial interventions to teach emotion regulation skills. Occasionally, you have to add a mood stabilizer, but I do that, with caution just because the side effects profile is so bad. If you have it associated with expansive mood, hypersexuality, inappropriate humor or behavior, risk-taking, then you're probably dealing with mania. And then, that's a really complicated management, and it's not something to be done in primary care. Or it could be a symptom of ADHD, a kid who's not treated, not diagnosed, or is undertreated. And sometimes, improving the symptomatic management of ADHD will help with, giving the kid a little bit better executive control. And I don't think this copied very well, so I'll just go through this, and then I think we'll stop and take some questions. So in other words, if you have irritability that's due to a stressor, substance abuse, sleep deprivation, then you want to deal with the primary problem. If it's related to mania, then that requires management with a mood stabilizer. If it's related to depression, then your first step will be to treat with an antidepressant. You may add a mood stabilizer if that's not sufficient. If a kid has ADHD, then you're talking about a stimulant or some other drug that's active against inattention and impulsivity. And if you have a kid with a behavior disorder, then your first step should be some kind of psychosocial treatment. But sometimes you do have to use a mood stabilizer. But again, I'm reluctant to do that because of the side effects. But sometimes you're forced into it. So just to summarize, imminent suicidal risk, it comes from a combination of distress and disinhibition, that the symptom clusters associated with distress include depression and anxiety. Insomnia can exacerbate distress. The symptom clusters associated with disinhibition are insomnia, behavioral disorders, substance abuse. Bipolar disorder is associated with both. And that the pharmacologic management of suicidal risk must be accompanied by patient and family education, careful monitoring of response and risk and side effects, and the judicious use of psychosocial techniques. We don't have any quick fixes, maybe ketamine, maybe not. That for anxiety and depression, SSRIs are the best pharmacological intervention. There are some drugs that are helpful for difficulty falling asleep. And that in the context of primary care, for kids with comorbid ADHD, that optimizing their stimulant management can help with lability that's associated with that. And then you can use that schema for a differential diagnosis in order to figure out what your next step would be with a kid where that's a serious problem. And anybody who wants a copy of these slides, you can write to me, care of Robin Martin. And I thank you for your attention. If we have time for questions, I'd be happy to take some.
Hi. You mentioned without further comment that antidepressants beat placebo by 10 to 20%. Some people think it's scandalous that they beat a sugar pill by such a small margin. Would you comment on that?
Yes. Well, I don't know if scandalous is the right word, but let me put it in context, and there's a gradient of scandal involved. If you look at the determinants of placebo response, and we published a paper, Jeff Bridge was the first author, in the American Journal in 2009, the placebo response is inversely related to the severity, and it's also positively related to the number of sites in the study. And so what's probably happening is some of these industry trials that are done very quickly with maybe not the greatest quality control are enrolling a lot of people that aren't severely depressed and are placebo responders. In the studies where they enroll people that I think were appropriate to get antidepressants, like the TAD study or Graham Emsley studies, then you have a bigger difference between drug and placebo. So you're talking about, I think the placebo response rate in TADS was 35%, and the drug response rate was 61%. So now you're talking about a number needed to treat of 4, which I think is a reasonable effect to use it. So the scandal is that these studies were not well done, I think, and not that overall antidepressants are used inappropriately. I mean, they may be, but that's another, but not after listening to this talk, they won't be, so. Yes?
Hi, Margot Adams. We met through the cyber world, but nice to meet you in person, finally. So I had a question about what research says about outcomes for adolescents and children who are chronically depressed, maybe perhaps the diagnosis of MDD, but for whatever reason go undiagnosed and untreated throughout adolescence. When they go on medication, if they go on medication as adults, how they react, would they react the same way as adolescents who've stayed on medication, were put on medication as adolescents, and have maintained that regimen through adulthood and up to adulthood?
So is your question what happens in chronic depression, or is it what happens with people that you have to maintain on medication?
Yeah, I'm just wondering what research outcomes are for kids who, for whatever resource, lack of resources, low parental empathy, go without a diagnosis and therefore without treatment throughout adolescence, but perhaps have something as severe as MDD. What are their outcomes like, or do we know?
Well, I mean, I guess we want to try and keep them from going in undetected. And I think that some of the strategies that we're talking about are either to co-locate mental health specialists in primary care or in schools, so that kids, the barriers for treatment are more are lowered. But other than that, I don't really. I'm not sure if I'm answering your question, but other than that, I don't really know what we can do.
Yeah, I work with a very specific low-resource population, so I asked because of that. Anyway,
so some of it's public education. I mean, I would say kids are much better at recognizing depression than they were 20 years ago. And so that's another thing that we can do is education in the schools. I don't think it should be resource intensive, but I mean, when I will talk to a kid and I'll say, do you ever go without sleep and talk really fast? And no, I'm not manic. I mean, they know. So I do think that that's another way in, is that you can get people to self-identify. But it's sure it's a problem. Oh. So, okay. So in the TAD study, I think they had a pretty wide range of SES. We didn't do as well in the Tortia study. And SES wasn't related to treatment response in medication. It was related to treatment response with psychotherapy. It was a negative predictor. And I think that we know that in general, there's a whole biological cascade that's set into motion with, early adversity, poverty, exposure to maltreatment, and exposure to domestic violence and so on. And there's evidence that although I haven't seen it in kids, that those folks are less likely to respond to any treatment for depression. And I think it's actually a really serious issue. In the study that we did, when we looked at combination treatment, SES wasn't involved, but the kids with a history of abuse did much worse in combination of psychotherapy and medication than medication alone. So I think trying to understand what's going on there, what are the differences, and are there different ways, strategies that we need to use to deal with folks who come from those kind of backgrounds, I think is an important question.